Welcome back to the new norm. I'm Dr. Lou Graham, brought to you by Midway Dental and Catapult Education. I've got Dr. Karson Carpenter for our final initial segment on emergency dentistry. The state of Pennsylvania was really the one to come out with the most strictest, I would say, guidelines on what emergency dentistry is. The ADA has talked about, here are our guidelines, that's on the ADA site. The state of Oregon is now saying only emergency dentistry, potentially up through September 20th. This is like an OMG, if you ask me, as far as trying to figure out all of this. And so I want to dive a little bit deeper into understanding from Karson thoughts on emergency dentistry. Okay, per the guidelines, Karson, let's start talking to our audience, our audience members about emergency medicine. Let's go with it. I'm going to let you start. I'm going to fire questions at you. Take it away.
Okay, that sounds good, Lou. I'll be glad to help out here because one of the important things is, let's face it, we have a lack of personal protective equipment. We're concerned about treating patients who may have COVID-19. So what we need to do is we need to treat only those that need to be treated. So I'd like to go into a little bit what constitutes a dental emergency and an urgency according to ADA guidelines. If you'd like, I'd be glad to go through that as I understand it.
Go with it. Go.
Well, the ADA would consider an emergency something that's potentially life-threatening. So we're talking about bleeding, cellulitis, anything that with between intra or extraoral swelling could compromise the airway. Same thing with trauma of facial bones. If it's trauma that could compromise the airway or potentially compromise the airway, that's a true emergency. Now, urgencies, that's a little different. We're talking about managing pain or managing the risk of infection. So we're talking about pulpitis, pain from pulpal inflammation, pericornitis, third molar pain, dry socket abscesses, an avulsion or luxation, a tooth fracture causing pain. Also, it could be a final cementation of a crown if the temporary is lost, but only if it's lost.
Right.
So I see that we're going to get a pushback from some patients who want to get things done. And some people might not be happy, but we have to let them know that during this time, these are the only things we can treat.
Right. So let's go into some specifics. Let's call it acute pain. Patient has a crown on a tooth, large restoration, there's some decay, whatever, but now they have true pain. They're up all night, it's prolonged, we've got a serious pulpitis. That's emergency pain, we would agree, correct?
Absolutely. You can't treat that one pharmaceutically anymore.
Okay, so either they're going to go to an endodontist they're prepared for this, or the dentist who's doing their own endo would go in, have to use aerosol, and as previously discussed, following the standard of care, rubber dam to minimize this. But that is an absolute indication in my eyes. What about if the fact that they want to finish the endo and do one-day endo? So let's just say one-day endo is, most endodontists, if they can do it, it's free of infection, they want to do one-day endo. Would you be opposed to a one-day endo procedure as part of emergency dentistry? I'm just curious.
Well, to tell you the truth, Lou, in my opinion, I think that would actually create less risk because once you're in there, you've got the rubber dam on, you're doing the work, let's finish it up. Why have a second chance to be exposed? Why have a second chance in another week or two when that patient may in fact have COVID-19 by then? I think that would be a good treatment plan.
Right, and I would put a permanent seal, even if whatever, I would put a permanent seal so we minimize, coronal micro leakage, because we have to assume we may not see that patient for a few months. And
exactly, it'd be a great time to seal it with some composite.
Yep, okay. So I'll give you question number 2. Okay, so patient comes in and they've fractured off a tooth, it's unsalvageable, creating pain. You take out the tooth. Now, I want to save the area, I want to save the socket for a future implant. I've explained it to the patient, I want to put a bone graft in to save the socket. Would you see that as part of emergency dentistry as a socket graft? I didn't discuss this with you previously. I'm just curious because then I'm going to go to the next question, which is going on out there. But let's talk socket grafting. General dentists do them all the time. Would you be opposed to a dentist trying to preserve the socket because we're not going to get this patient potentially back in for months and months potentially? Your thoughts?
Well, to me, absolutely, I have no problem with that. I'll tell you why. First of all, once you get to the socket graft, the risky time is already passed. Really, you shouldn't
Right.
be generating aerosols by placing in a membrane, by placing bone, placing a membrane, and placing some sutures. And this may be the only chance you have to preserve that bone. Absolutely, this could be
Exactly. Okay, so now I'm going to push it one more step. Patients in the chair, they've just lost tooth number 12, they've lost number 8, and now all of a sudden the surgeon is seeing this patient and they can place an immediate implant. You know this is going on. I'm not casting any judgment. It's all over social media. People saying you're doing something wrong, you're doing something right. You've got a surgical site there, and this surgeon places implants. You're going to create, I'm assuming, some aerosol, some. Talk to me about, is this ethical? What do you think? You've got the site there. What's your call on this? I'm just curious.
Well, here's my
Tough
feeling
one.
on that.
Yeah.
It truly is an ethical decision. But
Yeah.
I think that if I'm the surgeon in that case, I take a look, I say, look, I've just created some aerosols because I've extracted the tooth. I now have the tooth out. The patient is already anesthetized. I can save this patient time, money, trauma, and preserve bone by going to the next step and placing that implant. If this is an ideal case for an immediate implant, I think that would be a good call. That has to be an individual call, but that would be my call. That would be the right thing to do in that case. If there truly was an option to do it as a second stage implant, that might be different, but I have no problem with that, Lou. I'm not sure what your thoughts are.
You know, I'm going to go toe-to-toe with you, and I'm going to agree with you on this. My feeling is if I'm the patient, I'm numb, and I can have the implant placed and get onto what I call uneventful healing. The doctor's there. If there's any problems, obviously they're going to see them on an emergency basis. But again, if there are sutures that are going to have to be removed from the extraction, why not have to remove them after the implant if that's what's entailed? I think long-term, I think the chance of the aerosol issue with an implant placement is minimized. I think I do consider this ethical emergency dentistry if it's available to the patient. Yeah, it's just my thought on this. And Karson, we may get people throwing spears at us, but I'm thinking if I'm the patient in there and I've gone through the proper screening and everything else, I go, why not? I'm not doing this for money per se, just to bill, but I'm thinking as a patient, it's best for the patient.
Well, yeah, Lou, and you're trying to avoid a second surgical procedure for that patient with the risk of anesthesia, with the risk that that patient could have COVID-19 by the next visit. I see nothing wrong with that call, but it's got to be an individual call, of course.
I'm with you 100%, but it's also the same call. Temporaries only last so long. So if I'm in the office and my temporary on tooth number 19 is gone, I don't want to make another temporary, and I got the permanent crown there. I got all these crowns waiting to be delivered. I'd rather deliver it and save the patient from coming back to see me or me having to re-cement a temporary crown. So I don't call that a bad emergency visit if I have to do a permanent cementation versus retemporizing. Your thoughts?
Oh, absolutely. If a patient came in with a broken temporary, it's silly to make a new temporary. Place that crown. Now, if the emergency is that Mrs. Jones wants you to cement crown number 8, the temporary is perfect, but it's discoloring, that's different. Okay, that's different. That's not a true emergency. But a broken temporary, absolutely.
Yep, I agree. And there's those fine lines. I mean, it's like having a chipped tooth. We've had 3 patients call with chipped teeth, no pain. That's not an emergency to me. I mean,
Right.
first off, you shouldn't
It
be
used to
going
be.
out. There's no wedding pictures. It used to be. So I think we're redefining, I think pain is, I mean, I think emergencies really are dealing with pain, swelling, and probably dentistry. It could be, pain could be from a poor fitting denture, a broken denture, a broken temporary. But I really think we have to follow the guidelines of what true emergency dentistry is over these next 8 weeks. And I think that's the basis of this conversation today. You agree?
No, you're right. You're right. And we have to have whoever is answering our phone during this time as educated on this as we are, so that they
Right.
don't upset patients. They need to empathize with them, but they need to let them know
Yes.
why we can't treat that the situation that the patient thinks is an emergency,
Right.
but it really isn't. We
Right.
need a good communicator talking to that patient.
And I'm going to say this. We had Mark Genus on with his ICE teledentistry, now 2 episodes. I think if I can see the patient, communicate with them live on the computer screen, it makes it so much better for that interpersonal relationship. Like you're kind of patting them on the back or the shoulder going, you know what? This is not a true emergency. I'm with you. But I think that face-to-face interaction becomes huge versus just a phone call.
Oh, I agree. I think teledentistry can really make us look better to the patient and have them understand the situation. Because let's face it,
Yeah.
they want to talk to the doctor. I think these emergencies, I think teledentistry is a great idea, Lou.
Yeah, I do too. So as we close this episode, I think, Karson, here's what I'm going to do. I'm probably going to invite you back. I'm going to invite Tracy back. And I want to talk about what's going to happen in the new norm after emergency dentistry kind of gets pushed aside and we're going really back to work. I think we're going to be looking at a whole different viewpoint, scheduling, how do we get our patients in, how do we test them to make sure that they're not COVID carriers or that they have the virus. As I close this, give me your thoughts on what you're seeing in a few thoughts for the new norm going back in June, July, or August, or whenever that is. Yeah.
Well, I've thought about that a lot. Particularly for the young dentist out there, the dentist with $300,000, $400,000, $500,000 in debt, who's just purchased a practice, or any dentist for that matter, because this will be a good conversation you and I are going to have in the future, because there's going to be a lot of concerns about how to gain the confidence of staff long-term, how to gain the confidence of patients so they start coming back for routine care. That's going to be a very interesting conversation, and I'm concerned that if we don't do it the right way, it can really affect our business.
Yeah, I really agree. And on that note, and before I close this, I think that I'm seeing like certain products come to market. So for example, and we're going to see how the efficacy of these are, but for example, Midway Dental is bringing this really cool new plasma technology and how to disinfect a room, the aerosol of a room. And if we're in an enclosed room and it takes 15 minutes with this device to feel comfortable going back into it, we may have rooms that require an extra 15 minutes to turn over. I see new technologies coming into our world so we can practice safely, still with the OSHA guidelines that Tracy and Karson teach, and become even more important in our future. I just see these new products and technologies being very, very important going forth. And I think as offices, we're going to be practicing differently. There's no doubt about it. And this isn't negative. I think we're going to be having to practice smarter, especially when we reopen for what I call elective dentistry. And I'm sure, Karson, you would agree.
Oh, no, I agree. Absolutely, I agree. And I think it's going to take it to a better level. It's going to be a safer level, but we're going to have to find out how to make the business model work. That's what we need to talk about and think about for sure.
Yeah, and I think in upcoming episodes, we're going to talk about why you need an in-office dental plan, because if PPOs are still going to pay you fees that just don't cover these costs, this is going to be the right time that the industry says either PPOs have to wake up and really change how they reimburse us, or we just say goodbye to these traditionally, I'll say tradition insurance companies that really don't understand the new norm. With that, Karson, I can't thank you for all the segments you've done. I feel like you're my new BF, and we'll be talking really, really soon.
Very good.
Thanks
Lou.
so much, Karson.
Very good. Always enjoy talking to you, and look forward to the next one, of course.
Thanks, pal. Thank you. Lou Graham for the new norm. Talk to you soon. So let me be clear. We want to hear from you. We want to hear your questions. So what we want you to do is we want you to go to education@midwaydental.com. Shoot us your questions. We'll go right to the experts. I know I'm not the expert, so let's go ask the experts what we should be doing as our next step next week, the week after, and thereafter. I look forward to hearing from you.